Welcome to Critical Matters, a sound podcast covering a broad range of topics related to the practice of intensive care medicine. Sound provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
The use of an arterial catheter to invasively monitor blood pressure is common in the intensive care unit and is recommended for the treatment of patients with shock. In today's episode of Critical Matters, we will discuss arterial catheters in shock through the lens of the recently published EVERDAC trial, entitled Deferring Arterial Catheterization in Critically Ill Patients with Shock and published late last year in the New England Journal of Medicine. Our guest is Dr. Gregoire Muller, a critical care physician in the Department of Intensive Care Medicine and Resuscitation at the University Hospital Center of Orléans in Orléans, France. Dr. Muller is an accomplished clinician and researcher. He is the principal investigator and lead author of the EVERDAC clinical trial published in the New England Journal of Medicine. Gregoire, welcome to Critical Matters.
Hello, thank you for having me, Sergio.
I would like to start with just a general question about arterial lines for patients in shock. Is that dogma or evidence so far?
Before the EVERDAC trial, it was easier to answer this question. I think arterial line is a little bit of dogma and evidence. They are very useful for blood pressure monitoring, for blood sampling. I think we will discuss it later. And when I graduate in intensive care, it was very used to put arterial lines. So there is not a lot of evidence that arterial lines could be useful, but how can we monitor patient if we don't use arterial line? It was a question.
Excellent. And I probably trained even farther away from you back in time. And I remember in one of our ICUs where we really relied a lot on point of care testing. Everybody had an arterial line because we would sample them and try to figure out what was going on. But as you said, it's like many things in critical care, we do them because that's the way people before us did it, right? And it makes sense, but it's always interesting to study. And that's one of the reasons why I'm so attracted to the EVERDAC trial, because it's an example of an investigator-led initiated study that addresses something we do every day, yet we have never really taken the effort and time to study because it's hard. But tell us a little bit about what was the origin of the EVERDAC trial in your mind as an investigator?
So the beginning was a trial from my colleague and mentor, Dr. Thierry Boulin. He was the head of the ICU of my ICU, and he worked with Karim Lacal, located in Nantes, in France, and Stéphane Herman, who recently published in the New England the Amicanal study, and he's located in Tours. And the three of them worked on non-invasive blood pressure monitoring. They published, I think it was in 2009 in Anesthesia Analgesia, first study evaluating the accuracy of non-invasive blood pressure monitoring to assess mean arterial pressure. And at the beginning, they showed that the non-invasive blood pressure had a good accuracy to predict low MAP I mean below 65 millimeters of mercury. And next, they perform multiple studies in arrhythmic patient, in patient who were under vasopressor also, and they always showed a good accuracy of non-invasive monitoring to predict low MAP. And in the middle of the 2010 years, I think it was Alan Garland published in Chest an editorial discussing the fact that we always use monitoring in the ICU because our previous colleague did it. For example, the pulmonary arterial catheter, and since we have a lot of publication now to avoid systematic monitoring of arterial pulmonary pressure. At the beginning, we put this kind of catheter in a lot of patients. So it was a story of first evaluation of non-invasive blood pressure, and second, this editorial from Garland saying that beware that a lot of things we do are not have not been evaluated yet, and when they are evaluated, the result is not always a good result.
In general, the pros of having an arterial line are obviously we believe we have more accurate measurement of blood pressure minute to minute, whether it's very high or very low blood pressure, whenever we're using vasoactive drugs to raise or lower blood pressure, that we as clinicians believe to be helpful. And also you mentioned the blood sampling, but there's also, I guess, negatives to having an arterial line, some of them from the patient perspective. Can you comment on some of those potential downfalls of having an arterial line in every patient?
Yeah, about blood sampling, there is a lot of paper demonstrating that in patient with an arterial line, when you compare patient with a line and patient without, with the same gravity, the same severity, the patient with the airline are exposed to more frequent blood sampling that can lead to anemia and the need for blood cell transfusion. So arterial line may expose patients to non-appropriate blood sampling and anemia. There is also a risk of complications such as hematoma, pseudoaneurysm also, or infection. There is some data that arterial line may be infected as well as CVC, for example.
So that's a great example of unintended consequences. We do something because we have the ability to do it easier, right? And we don't think about the impact it might have on patients. Not to mention that patients probably don't find arterial lines when they're conscious and awake too comfortable, right? They can cause also pain and discomfort. And even though I guess a lower rate than central venous catheters, they can still get infected and are also a source of potential infection. So clearly something to consider, right, and worth studying. So let's talk about the EVERDAC clinical trial itself. What was the objective, and could you tell us about the design of the trial?
Yeah, the EVERDAC trial was designed to assess whether non-invasive monitoring using a brachial cuff is non-inferior to arterial catheterization in a shock patient in terms of death at day 28. So we compare two groups, the invasive group, and in the invasive group, the patient had to have an arterial catheter inserted within the 4 first hours after the randomization, and keeps the arterial line until day 28, except if there was futility criteria such as a very low dose of norepinephrine below 0.2. It was a tartrate of norepinephrine, not a base of norepinephrine. So I mean 0.1 in American base norepinephrine. And in case of futility criteria such as such as palliative care medical decision of palliative care. Do you want me to reformulate the answer, or it's okay for you?
No, this is perfect.
Okay.
Go ahead.
The inclusion criteria, we aim to include adult patient within the first 24 hours after ICU admission having an acute circulatory failure. The acute circulatory failure was defined by low blood pressure, systolic blood pressure below 90 millimeters of mercury, or mean arterial pressure below 65, and or the need for vasopressor, and at least one sign of tissue hypoperfusion, such as alteration of mental status, skin mottling, oliguria, elevated blood lactate below 2, and low central venous oxygen saturation. And the exclusion criteria were non-invasive blood pressure value displayed by the monitor, the brachial cuff placement impossible in case the patient was under extracorporeal Raman oxygenation. If the patient required high dose of vasopressor, it's the sum of norepinephrine tartrate plus epinephrine above 2.5 micrograms per kilogram per minute. If the patient had a severe traumatic brain injury, was obese, or refused to participate.
So
go ahead.
Yeah. Go ahead.
The intervention was in case the acute circulatory failure occurred within the first 24 hours, the patient was randomized with a stratification according the need for invasive mechanical ventilation, the center, and the vasopressor dose above or below 0.36. In case the patient was randomized in the non-invasive strategy group, no arterial catheter was allowed until day 28 or safety criteria, and the safety criteria were inability to monitor to display non-invasive blood pressure or pulse oximetry, the absolute need for arterial blood gas sampling after 5 consecutive failed arterial punctures attempts, the need for ECMO, or the need for high dose of vasopressors above 2.5. And the last, the need for high-risk surgery. In this case, the arterial catheter was allowed only during the time in the operating room and had to be removed within 4 hours after the surgery. And if the patient already had an arterial catheter at time of randomization and was randomized in the non-invasive strategy group, the arterial catheter had to be removed within 1 hour after the randomization. In case the patient was randomized in the invasive strategy group, the arterial catheter had to be inserted quickly within 4 hours and not removed until considered to be futile, such as low dose of norepinephrine without epinephrine and without hypoperfusion tissue signs, or medical decision of palliative care.
Excellent. Gregoire, in terms of general patient care, could you comment on any hemodynamic protocols that were indicated? Was that left to the discretion of the treating clinicians? Because this cohort was randomized, but obviously for obvious reasons, it wasn't blinded. People could see where the arterial line was.
Yeah, it's a very good question. Thank you. To be a pragmatic study, we did not provide algorithm or protocols to manage a patient in acute circulatory failure. We left it at the physician decision.
And in terms of outcomes, you mentioned the primary outcome was 28-day all-cause mortality between both groups, and this was designed as a non-inferiority trial. So the hypothesis was that non-invasive monitoring in patients with shock would be non-inferior in terms of this outcome to invasive monitoring, correct?
Yeah. We designed to answer the question, it's really safe to monitor patient without an arterial line. We choose to use a day 28 mortality to say, okay, you can use non-invasive blood pressure monitoring. The patient will not die more often than if you put an arterial line.
Could you comment on some of the secondary outcomes?
So the secondary outcomes were SOFA score, and the SOFA score decrease from 10 to 5 point in the week after randomization, and it's the same in both groups. There were also ventilator-free days, number of renal replacement free days, vasopressor free days, the mean duration of ICU stay, and the mean duration of hospital stay. We also recorded pain and discomfort in patients. We recorded also the number of blood sample in both groups, and that's it, I think.
In terms of the actual results, could we start by a description of the patient population, the number of patients, and then talk about the primary outcome and the secondary outcomes that you find most relevant?
Okay, so we randomized 110 patients, and 506 were randomized in the non-invasive group, 504 in the invasive group. 2 patients in the both groups were excluded because of consent issues. The population was a standard population of shock patient in ICU. The mean age was 64 years old. The 2/3 of the population were male. The SOFA score was 10 points. The mean SOFA score was 10 points in both groups. And the main cause of acute circulatory failure was septic shock, 52 and 57%. And the primary admission diagnosis was medical in 94% of cases. Most of patients were under mechanical ventilation, 67 and 68%. 90% were under vasopressor at randomization. In the invasive strategy group, 65 patients already had an arterial catheter at randomization, and most of them, 98%, underwent arterial catheterization quickly with a median time of 1 hour. In the non-invasive strategy group, 64 already had an arterial catheter at randomization that was removed for all but one patient. And 72 underwent arterial catheterization, mainly for safety reasons. The half 33 for high dose of vasopressor above 2.5, 20 for high-risk surgery with the requirement to remove the arterial catheter after come back in the ICU, 15 for failure to monitor blood pressure non-invasively, 7 for failure to monitor pulse oximetry, 6 for 5 puncture attempts failure, 6 because patient underwent ECMO therapy, and 6 for other reason. In the non-invasive strategy group, arterial catheterization was avoided in 85% of patients. And that's the first thing very important. And the second is we used to say that in shock patients, non-invasive monitoring doesn't work. And we observed that only 15 patients, in 15 patients, the monitor failed to show non-invasive blood pressure, and in only 7 patients, the monitor failed to show pulse oximetry.
And that's an important finding, I believe, because a lot of the push for arterial catheters over time was based on very small studies that had actually talked about the inability of non-invasive monitoring to detect very low blood pressures. But as technology has improved, and in this much larger study, you've demonstrated that it's a small group of patients in whom we can't get an adequate reading, correct?
Yeah, it's correct. And I think it's a very important result in our study.
Absolutely. In terms of some of the other secondary outcomes, obviously a lot of it was related to SOFA scores and the need for support of different organ failures. So you measure that in the number of mechanical ventilation free days from vasopressors, free days from renal replacement therapy. Any differences between both groups in that?
No, there were no differences between both groups. Just in vasopressor therapy, we can see a little bit more vasopressor use and less vasopressor free days in the invasive strategy group. But according to the journal Policy, we did not perform statistical analysis and no adjustment for multiplicity of tests. So it just it's not we can't say it's statistically relevant.
Perfect. Could you comment on some of the post-hoc safety and subgroup analysis that were done during the trial?
Yeah. For the primary outcome of non-inferiority in terms of deaths at day 28, we observe the same results in the 2 pre-specified per protocol analysis. And for the safety outcome, we recorded adverse events of special interest, I mean arterial line complication and non-invasive blood pressure complication in the other end. About the arterial line complication, we observed more arterial catheter-related hematoma and hemorrhage in the invasive strategy group. We observed a little bit less than 10% of patients having an arterial catheter-related hematoma or hemorrhage. We did not record the severity of this hematoma or hemorrhage, but 1 patient in 10 had it. And only few patients in the non-invasive strategy group, because only a few people had an arterial catheter in this group. about non-invasive blood pressure adverse event, we recorded pain and discomfort, and we recorded more day with pain and discomfort in the non-invasive strategy group. And that's a very important point of our study, because we recorded pain and discomfort only in awake patients that were able to assess it. So first, it was a very little group of patients in this study who were awake and able to answer the question, does this blood pressure monitoring give you some pain or discomfort? And also, I think that patients who are able to answer this kind of question, if they previously required an arterial line because of a big septic shock, at the moment they are able to assess their pain and discomfort. They probably don't need an arterial line for the future. So I think we did not assess the pain and discomfort as we expected. It's an issue in this paper.
Yeah. Well, and like you explained, those are limitations of the methodology that are imposed by the nature of the patients we're studying and what we're studying. But it's a fair point, right? The patients who reported this, by definition, were less sick because they were awake, and they were a smaller subgroup of the total population of over 1,000 patients. So the power of that finding, it will be diluted.
Yeah.
In terms of discussion, what were some of the other limitations of the trial from your perspective? And then we can jump into what you think these findings mean, and what was the conclusion of the investigators?
So, about the limitation, as you previously said, it was an open label study, but I don't know how we could have blind this blood pressure assessment. So, as I previously said, pain and discomfort assessment may not be complete because only few patients were capable to answer the question. The patients who were capable probably no longer need an arterial line if they had one. And we did not assess for pain associated with vascular punctures. And in the secondary outcome, we recorded more frequent arterial puncture for blood sampling in the non-invasive strategy group than in the invasive one. And we did not assess pain for that. This result suggests that the guideline to preferentially use the CVC for blood draws may have not been followed as anticipated also. We did not record workload and satisfaction of healthcare workers and mainly nurse. And that's, I think, an issue. And the recruitment of patients were mainly medical patients. So we did not include trauma or post-surgical patients. So it's difficult to extrapolate the EVERDAC results to this kind of population.
Like you mentioned earlier, this was highly predominant, what we would call a medical ICU or MICU population, which still obviously a very important and a large number of our patients in critical care. What was the conclusion of the investigators of the trial?
So the conclusion of the study was among critical inpatients with shock, deferring the insertion of an arterial catheter was non-inferior to an early insertion strategy with regard to death from any cause at day 28.
And one of the important aspects of this trial, Gregoire, is that not only it's a first in many ways, but there's nothing even close in scope of number of patients looking at this question. So, like we mentioned before, a lot of our practice was based on what other people did before us and dogma. And this is the first large randomized study that's trying to give us more insight into what is the real need or safety of using a less invasive strategy. Herbert Spencer said that the objective of research is not knowledge, but action. So let's talk about practical implications from your perspective. How do you monitor shock patients, and how do you incorporate the results of EVERDAC into your day-to-day practice?
Yeah, thank you for the question. By now, we change our practice. Previously, the arterial line was a sort of component of a welcome bag at ICU admission. Welcome in ICU. I will put you a chest tube, a CVC, an arterial line. I will intubate you and put under mechanical invasive ventilation. From now, we can say that arterial line is not the urgent things to do when you admit a patient for acute circulatory failure. You have to do a diagnosis. You have to give fluids, some vasopressor, some antibiotics. You have to put your patient on a CT scan or to the operating room to be treated, but don't take the golden hours to put an arterial line. It's not a welcome bag. In case your patient is still very severe despite all your medication and worsening few days later, and you need other things than only the MAP assessment, maybe you can put an arterial line to have other information.
In terms of it, and that's an important lesson, right? More and more we're seeing that sometimes doing less is focused and better for patients. But in addition, the arterial line is a diagnostic procedure, and what really makes a difference is our interventions. So focusing on interventions up front seems to be safe from the results of the EVERDAC, starting with non-invasive, probably in most patients will work initially. And then, like you said, we're not saying that do not use arterial lines, but to be more thoughtful about which are the patients that will actually, the benefits outweigh the risk, and in whom you should proceed then to an arterial line.
I think that the patient who would benefit from an arterial line are patients in whom we need to assess fluid responsiveness, for example, using a pulse pressure. We do not have with a non-invasive monitoring. If you need cardiac output monitoring also, and perform transpulmonary thermodilution. In case of non-pulsatile patient under a VA ECMO, and in patient in whom you need to assess extravascular lung wear or things like that. I want to give you some information for all the people that are hearing this podcast. The non-invasive monitoring of blood pressure only measure the mean arterial value. And it's a very important thing. The systolic and diastolic values the monitor gives you are not measured. They are extrapolated with an algorithm, a computing algorithm of the monitor. So the only thing that is really accurate is the mean arterial pressure. And in most cases, you only need the mean arterial pressure to resuscitate patient with shock. And In some cases, you will need other information, pulse pressure or diastolic pressure to assess vasoplasia, for example, or things like that. So in most cases, only the map and the non-invasive monitoring is the good one. And in some cases, you need more information, and this is the patient in whom it's necessary. It's okay to put an arterial line.
Excellent. What are areas that are still unanswered and potential targets for future research in your mind, Gregoire?
We don't have the information for surgical and post-trauma patients. And I don't know why it could be different, but we don't have the data. And I think there is a lot of research to do about blood sampling and CVC blood sampling to avoid arterial line blood sampling and to avoid transcutaneous needle punctures that are painful. We also need to assess the nurse workload in case the patient don't have an arterial line, because I think it needs more nurse work if the patient don't have an arterial line. And we did not assess that, and it's a question.
And again, just want to thank you for conducting such a wonderful trial. It gives us a lot of pause, and it's a reminder that a lot of the things we do on a daily basis have not been studied, and studying them has a lot of value because it opens new questions, but also helps us hopefully tailor our treatments in a more thoughtful way for each patient. Not every patient needs an arterial line. Choose the right patients. And it's quite interesting, Gregoire, how these pendulums swing, right? When I was training, everybody got a PA catheter. Then nobody got a PA catheter. And now we're realizing that some people do benefit from a PA catheter, probably.
Yeah, also.
Yep. And I think that in many other examples, as in the arterial lines, we probably will see that in light of this wonderful trial that you and your team have published.
Yeah, I totally agree.
Gregoire, we love to finish the podcast with a couple of questions that are unrelated to the clinical topic. Would that be okay?
Yeah.
The first question relates to books. Is there a book that has influenced you significantly, or a book that you have gifted often to friends?
Yeah. So I'm not a bookworm. I'm not a big reader, but I remember that one of my colleagues, Stefan Herman, co-author of this paper, they gave me Getting Things Done from David Allen. And it's a book to learn how to organize your day, your week, your months, and probably your life. And I read it with big interest, and I use all the method provided by David Allen in many tasks of my days and weeks.
Excellent. And I think Getting Things Done is really a GTD that we call it here in the United States. After David Allen's publication became like a big thing in many circles. But really, it's a great read. And what I find is the concept that what stresses you, it's what's lingering in your brain or what you think you might forget, right? So when you have a method to get rid of that, I call it my brain dump, right? Yeah. It liberates a lot of bandwidth to think about more important things. So we definitely will link that in the show notes, and we'll thank David Allen since he probably helped you get this trial completed. Correct?
Probably, I don't know, but I put a lot of things out of my brain about EVERDAC thanks to David Allen. Yeah.
Excellent. Second question relates to changing your mind. Could you share something you changed your mind about over the last few years?
Yeah, it's the need for invasive procedure in the ICU, because when I graduated in the ICU, I loved to perform invasive procedures, and now I try to demonstrate that they are not all required.
Excellent. And I do believe that's a change in a lot of our careers, because like you said, a lot of our colleagues who gravitate towards intensive care medicine, like the procedural aspect, the nature of critical illness. And it's fun to do a lot of these procedures, right? But maybe not so much fun for the patients. And again, the key, I believe, Gregoire, is to be thoughtful about when we do things to patients, to really pause and consider, right? Is this really going to make a difference or not? What does the evidence support in this particular patient?
I totally agree, yeah.
To close, is there a thought or quote or general thought that you would want every listener to know as we finish?
I used to say to my resident that you have to treat patients the way you would want or your loved ones or yourself be treated.
I think that's a great concept in life in general, but definitely something we can apply in the ICU with a little bit more vehemency. Gregoire, thank you for sharing your time with us. Thank you for sharing your knowledge, and especially thank you for being willing to talk with me in English, since I speak zero French. So I have learned a lot, and look forward to having you back with further studies in the ICU.
Thanks a lot, Sergio. Thank you.
Thank you for listening to Critical Matters, a sound podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound's transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.